Hello, my name is Sam Lamb. In this segment of the narrated pediatric bedside ultrasound lecture series, we're going to talk about diagnosis of appendicitis. The objectives of this lecture are to describe the equipment and patient setup for bedside ultrasound diagnosis of appendicitis, to demonstrate the typical ultrasound appearance of appendicitis, to review the published literature on diagnosis of appendicitis by ultrasound, and to discuss the potential pitfalls of ultrasound diagnosis of appendicitis. Let's start with a couple of case scenarios. First, you have a 15-year-old male who complained of abdominal pain for one day. He denies any fever, vomiting, diarrhea, dysuria, or hematuria. He points to the mid-lower abdomen when asked about where his maximal pain is. He's tended to palpation on the right lower quadrant without any guarding or rebound tenderness. He had an otherwise normal physical exam. Let's assume this kid is your typical skinny teenager. In many ways, he would be the perfect candidate for bedside ultrasound diagnosis of appendicitis. He's got the ideal body habitus. It's able to tell you where it hurts. It's able to hold still during your ultrasound exam, and you don't have to worry about any intrapelvic organs. In the second scenario, you have a 20-month-old female brought in for fever and vomiting. The abdominal exam was difficult due to crying. She failed oral rehydration, so an IV therapy was given. When she finally got a moment of peace and quiet, you snuck in a quick physical exam and thought that she might have some right lower quadrant tenderness. Now you're at a critical decision point, and the parents are wondering what you're going to do next. Suppose you work at a community hospital without 24/7 ultrasound coverage, or the ultrasound tech on call is not comfortable scanning little babies, and you have to transfer the child if a surgical condition is found. In this case, being able to make the diagnosis of appendicitis using bedside ultrasound would make you a rock star to the parents and make the disposition a lot more straightforward. So why should we learn how to diagnose appendicitis by ultrasound? Because appendicitis is a common surgical condition in adults and children. Because formal ultrasound by radiology is not always available 24/7 in many hospitals. Because bedside ultrasound machines are now widely available in many emergency departments throughout the country. Because bedside ultrasound is much faster than CT, and we can potentially make a diagnosis and disposition in 5 to 10 minutes. Because it is consistent with the ALERA as low as reasonably achievable ionizing radiation dose principle. Because children's body habitus are uniquely suitable for ultrasound studies. In other words, there isn't much in the way of sound wave penetration. The preferred ultrasound probe used to diagnose appendicitis is a high-frequency probe in a range of 5 to 10 MHz, because most of the anatomical structures we're interested in are rather shallow. In most cases, this would mean using an ultrasound probe with a flat footprint on the machine. Nevertheless, some of the images in the following slides were obtained using a specialized curvilinear high-frequency pediatric probe. Whenever possible, you should ask the patient where it hurts the most and start your scanning from there. In order to visualize potential appendicitis, graded compression technique should be used. In other words, slow and steady pressure should be applied via the ultrasound probe onto the abdominal wall in order to displace the overlying bile gas. Most commonly, the appendix is found anterior to the iliac artery and vein and the psoas muscles, indicated by the blue oval in the slide. What we're looking for on the ultrasound are a non-compressible blind-ending tubular structure, focal fluid collections, target sign on transverse view with an outer diameter 6 millimeters or greater. And I've come up with a mnemonic to help you remember this. When you've found these ultrasound signs, you have nothing further to do. Other ultrasound signs that support the diagnosis of appendicitis include the lack of peristalsis, presence of fecalith, and hyperemic bile walls, and we will be going through each of these findings in the following slides. Shown here is a blind-ending tubular structure typical of what an appendicitis looks like on ultrasound, and it measures over 10 millimeters. This is another picture of appendicitis. In this case, the blind-ending tubular structure is immediately below the peritoneum, indicating excellent graded compression. The structures above the peritoneum are abdominal muscles and overlying skin and soft tissues. And the circular structure underneath the appendix is the iliac artery. The next slide is a zoom-in picture of intra-abdominal free fluid, which is the hypoechoic area in the shape of a lightning. Here we have appendicitis seen in a transverse or short axis view given a target light appearance. This is a zoom-in view of a fecalith and the distal appendix with shadowing. This is an inflamed appendix showing increased perfusion on interrogation with a color Doppler. Putting it all together, this is a clip showing appendicitis as a blind-ending tubular structure being compressed in real time and not quite budging. It is right underneath the bright white line of the peritoneum and above the iliac vessels and medial to the psoas muscle. You can also see it's quite inflamed and surrounded by free fluid. In the radiology literature, ultrasound has been found to be 88% sensitive and 94% specific for diagnosis of pediatric appendicitis in a recent meta-analysis, though the range of these numbers are quite high depending on the individual studies. And this is compared to a sensitivity of 94% and a specificity of 95% on using CT to diagnose appendicitis. To date, there have been 2 published studies on best ultrasound diagnosis of appendicitis in the emergency department setting. Chris Fox and his colleague at the UC Irvine did a study on 132 patients with suspected appendicitis. 36% of them were under 18 years old. The prevalence of appendicitis was 43%, meaning that they're dealing with a moderate clinical suspicion group. Ultrasound was performed by attendings and residents after brief training. They found that best ultrasound was 74% sensitive and 85% specific in the pediatric population. Dr. Chan and colleagues conducted this study in an emergency department in Taiwan, enrolling 147 patients in the ultrasound group, though they did not specify how many of them were pediatric. The prevalence of appendicitis is much higher in the group, between 68 to 75%, and the training of the physician sonographer was much more extensive. Interestingly, best ultrasound was found to be 96% sensitive, but only 68% specific in detecting appendicitis, and that's in all comers and not just the pediatric population alone. Now, I'm not sure if the difference in the results are completely explained by the difference in training or the prevalence of disease in this population, but the numbers do seem to fall in the confidence range we saw in the previous slide. To put these numbers in perspective of clinical decision making, let's look at this diagram from an article in the Annals of Internal Medicine. This assumes that ultrasound has a sensitivity of 86% and a specificity of 81%. If you start with a low to moderate clinical suspicion or pretest probability, say between 20 to 60% on the horizontal axis, a positive ultrasound would push your post-test probability into the moderate and high-risk categories respectively. But a negative ultrasound doesn't change the post-test probability much in the low-risk category, and in case of moderate clinical suspicion, only lowers the post-test probability to around 10% or so, which is usually not enough to completely rule out the condition. A negative CT, on the other hand, essentially rules it out until you get to pretty high pretest probability. In other words, bedside ultrasound can be used as a screening examination with patients with low to moderate clinical suspicion for appendicitis, and this is especially valuable in emergency departments without 24/7 ultrasound technician coverage. The following is a suggested algorithm in the use of bedside ultrasound for diagnosis of suspected appendicitis. In patients with low to moderate clinical suspicion for appendicitis, those that have positive screening ultrasound should be evaluated by surgery. However, appendicitis is not completely ruled out in those that have negative bedside ultrasound studies, and either further testing or serial abdominal exam should be considered to risk stratify the patient. On the other hand, if there's high clinical suspicion for appendicitis, bedside ultrasound can be performed if there's minimal delay of care. Definitive management, such as surgical consultation, should be sought as soon as possible. Needless to say, the operator has to have a reasonable level of confidence in his or her bedside ultrasound skills in order to apply the algorithm. Next, we're going to talk about the potential pitfalls in using ultrasound to diagnose appendicitis at the bedside. Because ultrasound by its nature is operator dependent, false positives and false negatives tend to be higher in the hands of an inexperienced operator. Factors such as excessive bile gas, obesity, abdominal guarding, and uncooperative patients can reduce the quality of the study. Inflammation from Crohn's disease or tubal ovarian abscess can cause serous edema and thickening of the appendiceal wall. Inflamed Makos diverticulum can mimic appendicitis. Perforated appendix can lose its targetoid appearance. Focal appendicitis and retrocecal appendicitis can be difficult to pick up. Most important of all, failure to visualize the appendix on bedside ultrasound does not and should not rule out appendicitis. Going back to case number 1, you have a low to moderate clinical suspicion for appendicitis. A positive bedside ultrasound should be enough for you to convince a surgeon to take him to the operating room, while a negative ultrasound does not necessarily rule out the condition. In case number 2, your clinical suspicion is a little lower. Bedside ultrasound can help you look for conditions such as intussusception and appendicitis and make a timely disposition in case of positive results. It is reassuring in case of negative results, but I would recommend getting a formal study if symptoms persist. In summary, bedside ultrasound can be a very useful screening exam, especially in a low to moderate clinical suspicion population. A high-frequency probe is recommended in order to visualize a relevant anatomy, along with graded compression technique. Look for nothing further to do, i.e., non-compressible blind-ending tubular structure, focal fluid collection, target sign on transverse view, and an outer-to-outer diameter 6 mm or greater. A negative breast ultrasound does not exclude appendicitis. This concludes the lecture, but please feel free to contact me for any questions. Thank you.